get going. So what we're going to do today, last time we'd gotten as far as delivering the filtrate, delivering that fluid to the distal convoluted tubule. And last week's discussion, last Friday's discussion, was mostly centered around the idea of the macula densa cells in the distal convoluted tubule and the release of adenosine from those macula densa cells affecting glomerular filtration rate through the so-called tubuloglomerular feedback. We're going to pick up this idea of what's going on in the distal convoluted tubule again today. But now what we're going to talk about is the distal convoluted tubule as being the last site at which we can reabsorb sodium and a last site where we can begin to now regulate the sodium and chloride concentrations in the distal convoluted tubule. We're going to find that this reabsorption is, at least to some extent, under hormonal control. That the major hormone that we're going to talk about here is aldosterone. As the name implies, aldosterone is a steroid hormone. Effectively, what it's going to do is it's going to upregulate genes because steroid hormones are transcription factors. And the genes that particularly are going to be upregulated by this steroid hormone are the so-called epithelial sodium channels. These are going to be specialized epithelial sodium channels in the apical membranes of these distal convoluted tubule epithelial cells. Now, if you imagine here, you simply put a sodium channel in the apical membrane. Remember that we still have something like 50 millimolar sodium in the extracellular space and only 10 millimolar sodium inside the cell. So now we have a sizable gradient driving the sodium ions into the cell through these so-called ENaC channels. But as these cells begin to fill with sodium, one of the things we need to do is pump the sodium out. So the other character that's going to be regulated by aldosterone is the sodium-potassium ATPase in the basilar membrane. So what effectively we're going to be doing then is pumping out the sodium from the tubular region across the apical epithelium of these epithelial cells across the basilar membrane, pumping it out, and then allowing that sodium to be taken back up into the blood vascular compartment in the peritubular capillary. Just as we saw with the proximal convoluted tubule, there again is going to be a peritubular capillary snaking its way around the distal convoluted tubule. Then the next character we're going to talk about, and again, these are in cells associated with the distal convoluted tubule, but we're going to find that these are the so-called juxtaglomerular cells. The juxtaglomerular cells are actually modified cells in the afferent arteriole. And what these modified cells in the afferent arteriole do is they release renin. They'll actually recognize hypovolemic shock, and we'll talk a little bit about how this happens. Now, under normal circumstances, one of the things I want to point out here, because I want to tell the story from an extreme case, under normal circumstances, as you're quietly sitting here, you're using this renin-angiotensin pathway to regulate and fine-tune the kidney function. But the way I want to tell this story is from an extreme case where there's been some kind of a tragedy and you've lost a lot of blood. And now, under cases of hypovolemic shock, the body is trying to bring itself back to balance. And one of the places where this is going to happen is in the so-called renin-angiotensinogen pathway. Renin is being released by the juxtaglomerular cells, and they're actually being released by a lack of stretch. And what will then happen is the renin is released into the blood vascular system. The renin is just an enzyme. It's nothing fancy. It's just an enzyme that has a particular target. The target for the enzyme is something known as angiotensinogen. The angiotensinogen is now the target for renin. Renin now will clip out a short peptide from angiotensinogen and convert that into angiotensin 1. Angiotensin 1 then is converted into angiotensin 2 by a series of enzymes on the capillaries, mostly in the lung. And this is called the ACE, or angiotensin converting enzymes. And we'll talk a little bit about this because this is one of the places where systemically we can control blood pressure. We'll try to spin this tale, though, in terms of what happens in cases of hypovolemic shock and how this will help regulate blood pressure. Then, The regulation of the blood pressure actually comes from the role of the angiotensin II. We're going to go through this Rube Goldberg series of events of renin, angiotensinogen, angiotensin I to angiotensin II, and the angiotensin II is going to be the active player. Angiotensin II is going to bind to receptors in arteriolar smooth muscle, causing arteriolar muscle contraction. So you can imagine here how effective that's going to be in the case of hypovolemic shock. Basically, you want to decrease the overall volume of the blood vascular compartment, and you do that by causing smooth muscle contraction. But it also works day in and day out. So you're regulating to some extent your blood pressure by using this pathway. And we'll see that one of the places where we can now affect blood pressure, systemic blood pressure in cases of hypertension, is we can in fact block the receptor for angiotensin II, or in some cases prevent the generation of angiotensin II in the first place. And we'll talk a little bit about that. Then we're going to move from the distal convoluted tubule into the next way station. The next way station is going to be the collecting duct. And remember, we've drawn the collecting duct a couple of times. The collecting duct is again an epithelium-lined tube. But this collecting duct, as the name implies, is going to be receiving fluid from the distal convoluted tubule. And as it receives fluid from the distal convoluted tubule, that fluid is now going to be passed in the collecting duct across the cortico-medullary gradient. We've drawn this a couple of times. It's important to recognize that the collecting duct itself traverses the cortico-medullary gradient. If you put your phone away, I'd appreciate it. It begins in the cortex, goes all the way across the medulla, and these collecting ducts then empty into the renal calyx. So this will be the last place where we can, in fact, regulate the reabsorption of fluid. Now, from our story here, we're going to tell the story from the point of view that the distal convoluted tubule is the last place where we can take up ions. But we still have a place in the collecting duct where we can regulate the reuptake of water. And we're going to be taking up water out of the collecting duct under the control of a hormone. This is a hormone we've talked about in the past. The hormone that we've talked about in the past is something called vasopressin. Vasopressin is released from the posterior pituitary. Remember, there are only two hormones released from the posterior pituitary, oxytocin and vasopressin. Vasopressin then binds to a G-protein coupled receptor on the basolateral membranes of the epithelial cells forming the collecting duct. The binding of the hormone to the G-protein coupled receptor now increases exocytosis. There are vesicles stored within these epithelial cells that contain aquaporins. The aquaporin 1s are exclusively found in the descending limb of the loop of the nephron, and they're not under any control. They're always there. They're said to be constitutively active. Whereas the aquaporin 2s, in fact, are under regulation of the vasopressin and will actually insert these aquaporin 2s into the apical membranes of these epithelial cells, and now then use the corticomedullary gradient, the ever-increasing salt concentration in the interstitial environment, to cause the concentration of fluid inside the tubule. So we'll walk our way through that, and then finally we'll finish with a discussion of the vasorecta. The vasorecta always gets short shrift, but it's really quite important. What the vasorecta is it's an extension of a capillary. It's effectively a capillary that branches off the efferent arteriole, much like the two peritubular capillaries. But now this tube, this capillary, is going to extend all the way across the corticomedullary gradient and run in parallel with the juxtamedullary nephron. And what we'll see here is that these blood vessels will now be very permeable, and they'll exchange between the blood in the vasorecta and the interstitial space, whatever ions and small molecules there are. So we'll then have another equilibrium story. But we're going to set this up in such a way that the vasorecta runs in parallel with the juxtamedullary nephron, but the flow of fluid through the vasorecta is opposite to the flow of fluid through the nephron, and therefore forms a kind of countercurrent exchange. You don't need to do it this way, but I think it's easier to understand it from that point of view. So what we want to do here is we're going to start here with the reabsorption of sodium in the distal convoluted tubule. Now, one of the things I want you to hold on to as we work our way through this is the idea that where sodium goes, water follows. Fundamentally, this is simply saying that we have an osmotic gradient that we're going to set up with the sodium. So wherever we put sodium, water is going to follow. So we're going to see here that when we move the sodium from the distal convoluted tubule back into the blood vascular compartment, water is going to follow. We'll think about that in terms of blood pressure and a number of things. But let's draw this in terms of the epithelial cells. So these are meant to be the epithelial cells of the distal convoluted tubule. These are epithelial cells of the DCT. And then snaking around the tube of the distal convoluted tubule on the outside of the interstitial space will be this peritubular capillary. Now, if we say that fluid flow is in this direction, then this structure here will be the ascending limb. And this is now going to empty into the structure known as the collecting duct. Now, we said last time that in the distal convoluted tubule, by the time the fluid comes up through the ascending limb and has been exposed to all of those transporters, that the concentration of ions in the distal convoluted tubule is in the neighborhood of about 50 millimolar sodium and 50 millimolar chloride. That we have managed to reduce these concentrations to these levels. Now, the next part of the story is going to be one that's, for most of us in this room, is ancient history. There was a time long ago when we wanted to be careful that we didn't excrete too much sodium and chloride. And so what we did is we had these careful mechanisms to reabsorb as much sodium and chloride as we could. And that's what we're going to talk about here. In the distal convoluted tubule, we're going to talk about the reabsorption of sodium under hormonal control. Now, recognize that in our modern diets, we have so much extra sodium that we don't need to be careful to reclaim all the sodium as it passes by. But we still have these mechanisms. And if you put yourself on a very low sodium diet, you will introduce these mechanisms to take that sodium back up again. Now, the first player here, I'm going to put this one in orange, is that out here on the apical membranes are these molecules known as epithelial sodium, spell it out, channels. We abbreviate these as ENaCs. The ENaCs are simply sodium channels located in the apical membranes. If you take a course in neurobiology, for example, you're going to find another place where we run into these ENaCs is in the epithelial cells of taste buds. And these ENaCs now are going to allow sodium to cross this membrane in your taste buds. It will tell you things taste salty. Here we're going to use the ENaC as a means of reclaiming or reabsorbing sodium. So among these sodium ions that are out here in the lumen at 50 millimolar, remember the inside the cell, the cytoplasmic concentration of sodium is no more than about 10 millimolar sodium. So we have a pretty substantial gradient, fivefold gradient. And we can now allow the sodium to diffuse down across its concentration gradient. And then in purple here, on the basolateral side, will now be a sodium-potassium ATPase. So again, as we slowly fill up these buckets with sodium, as the sodium runs down its concentration gradient, we can maintain the intracellular concentration of sodium around 10 millimolar by pumping the sodium out into the extracellular space and allowing that sodium then to move back into the blood vascular compartment. Water will always follow sodium. Wherever sodium goes, water follows. So as the sodium is moving in that direction, we're also returning water into the blood vascular compartment. So you can imagine if you don't have much sodium in the outside world, what you want to do in the distal convoluted tubule is take up as much of the sodium as possible. But sodium influx will also vary from day to day. So what we find is that low sodium, which is basically low osmolality, will signal the adrenal cortex to release aldosterone. Aldosterone is a steroid hormone. So one of the characteristics of these epithelial cells located out here in the distal convoluted tubule is there will be cytoplasmic proteins. These are cytoplasmic receptors for aldosterone. Well, let me remind you of the kinds of things that these cytoplasmic receptors can do. So that if we draw one of these typical cells, and out here in the cytoplasm in red, we have an aldosterone receptor. This is an aldosterone receptor. The binding of aldosterone to the cytoplasmic end of the molecule will then, if you'll recall from our stories in the endocrine system, it will signal that receptor bound to the aldosterone to go to the nucleus. And in the nucleus, the aldosterone with its bound receptor, the aldosterone hormone receptor, hormone receptor complex, turns on genes. It's, after all, a transcription factor. And it should come as no surprise then that the genes that are going to be turned on here are going to be the genes for ENaC and sodium potassium ATPase. Now, for most of us sitting in this room who have plenty of salt in their diet because it's mighty tasty, we don't really need to do too much in the way of inducing these genes. We'll basically simply let the sodium and chloride, which we have excess of, come up into the distal convoluted tubule, spill over in the collecting duct, and go to the outside world. So we'll eliminate that extra sodium. But if you were under circumstances of a shortage of sodium in the environment, in your diet, then you would upregulate these genes through the action of aldosterone. And the aldosterone then would work in this way to return the sodium followed by water into the blood vascular compartment. So any questions on that? This hormonal control through a steroid hormone. The next thing I want to do here is on the next panel, if we get rid of this story of the gene transcription translation. What I want to do following this is now I want to change the story just a little bit. And I want to tell the story from the point of view of the so-called juxtaglomerular cells. And I'll take this panel and describe it as juxtaglomerular cells and the release of rennin. I'm going to show you a slide here because I think this is the easiest way to describe this. And it's a slide that we saw last week. And it's worth looking at this simply because of what it's shown us before. But there's another set of characters I want to tell you about that we didn't talk about last week. Again, here's the afferent arteriole, feeding blood into the glomerulus. Here's the efferent arteriole. And now these sort of aqua-colored cells, these guys sitting right out here on the surface of the afferent arteriole. These, in fact, are the juxtaglomerular cells. And these are going to be the players we're going to talk about next. We're going to talk about these juxtaglomerular cells, and we're going to talk about them in terms of an extreme case. The extreme case is hypovolemic shock. So when we talk about hypovolemic shock, what we're really talking about, hypo meaning below, volume meaning the volume of the blood vascular compartment, in hypovolemic shock, there's been sort of a hemorrhage. You've lost a lot of blood. So now imagine if you've lost, 3 or 4 pints of blood, a considerable amount of blood. What's happened to the volume of blood in your blood vascular compartment? And therefore, what's happened to the extension of all of those tubes because of that volume? Well, it's gone down. Now, if you remember from that image, there is this afferent arteriole. And blood is flowing through the afferent arteriole. That blood is taking up space. Because it's taking up space, it's putting a certain tension or certain stretch on the walls of the afferent arteriole. Well, along with the cells in the afferent arteriole, I'll put these in as a few ovals. These are the juxtaglomerular cells. Juxta meaning just on, glomerular. They're right on the afferent arteriole heading into the glomerulus. What they monitor is stretch in the afferent arteriole. So then under the cases of loss of blood, then there is a lack of stretch on this afferent arteriole simply because we've lost volume. This lack of stretch signals the juxtaglomerular cells. Say a lack of stretch signals the juxtaglomerular cells to release a molecule called renin. So this gives us a mechanism under hypovolemic shock where we secrete renin. Now, renin itself is not a hormone. Renin itself is a proteolytic enzyme. And as such, this proteolytic enzyme will now digest a peptide from a blood plasma protein called angiotensinogen. It's worth taking a look at this for a moment. Whenever you see this suffix, OGEN, this means an inactive precursor. So angiotensinogen is not active. But what happens is the angiotensinogen is now a target for renin. So if we would do this as a box, we see renin attacks angiotensinogen. When the renin clips out a peptide for angiotensinogen, it converts angiotensinogen into a new molecule. The new molecule simply has a couple of amino acids clipped free. This is called angiotensin 1. So angiotensinogen is the inactive precursor, but when renin clips out a bit of its amino acid sequence, it converts angiotensinogen, which is inactive, to angiotensin 1. Angiotensin 1 then binds to another molecule here called angiotensin converting enzyme. We'll often abbreviate this as ACE, angiotensin converting enzyme. Now, ACE is a protein that's found as a transmembrane protein on endothelial cells throughout the capillary beds. Simply because we have so much surface area in the lung, we commonly associate this ACE with the pulmonary capillary beds. But fundamentally, what it does is angiotensin converting enzyme. As the name implies, it converts angiotensin 1 into angiotensin 2. So the major initial player is angiotensinogen. But angiotensinogen is converted to angiotensin 1 by renin released from these juxtaglomerular cells. Then once we've generated angiotensin 1, it still doesn't have much of an effect. Angiotensin 1 then has to be converted to the active form of angiotensin 2 by using the angiotensin converting enzyme located on the endothelial cells of the blood vascular system. Now, angiotensin 2 binds to receptors on arteriolar smooth muscle throughout the vasculature. So let's walk through this. We go back to the idea here that we've had a loss of blood. Loss of blood reduces the volume of fluid in the blood vascular compartment. As the volume of fluid in the blood vascular compartment goes down, the amount of stretch on the walls of these afferent arterioles is reduced. As we reduce the stretch, that signals these juxtaglomerular cells to release renin. The renin itself doesn't do anything. It's just an enzyme. But it finds angiotensinogen that's out in the blood plasma, converts it to angiotensin 1, then other transmembrane proteins in endothelial cells convert angiotensin 1 to angiotensin 2, and the angiotensin 2 now binds to arteriolar smooth muscle to reduce the overall volume of the blood vascular compartment and thereby increase blood pressure. In this way, we can compensate for the loss of blood through hemorrhage. Now, the truth of the matter is this is also a really important pathway in everyday life in controlling blood pressure. And in fact, one of the earliest and still most common ways of regulating high blood pressure, hypertension, is to block ACE. So we have something known as angiotensin converting enzyme inhibitors. So now what we do is we give people drugs that will block the angiotensin converting enzyme. And if we don't convert angiotensin 1 to angiotensin 2, then there's not much effect on the smooth muscle, and then blood pressure tends to go down a little bit. So this is one way we control high blood pressure, because under normal circumstances in these individuals, blood pressure is too high. Maybe it's 140 or so in the systolic range. So then what we do is, because we're constantly using this generation of angiotensin 2 to cause constriction of smooth muscles, we now block this pathway. And typically we block the pathway at the site of conversion from angiotensin 1 to angiotensin 2. And in so doing, what we do is we now get a little bit of loss of contraction of that smooth muscle and thereby a lowering of overall systemic blood pressure. So it's really pharmacologically an important place where we regulate blood pressure. This has been around since the 1930s. Now, actually, some of the more modern drugs that work in this pathway will actually bind to the angiotensin 2 receptor on the smooth muscle. So any questions up to there? So now we have these players out here regulating the blood pressure. Now, I'll say this in passing, and if you hold on to it, that's all well and good. But one of the things that the aldosterone will do is the aldosterone now will increase the reuptake of sodium and thereby increase the following water to increase blood pressure. So there's something known as this renin, angiotensin, aldosterone pathway. So that when you have a loss of blood, like we've seen above, one of the side effects, one of the ancillary effects, will be to increase the production of aldosterone, which will then increase the production of sodium channels and increase the reuptake of water to help elevate blood pressure. So all of these guys are working together. And in the case that I've shown you here, the extreme case, they certainly works that way. But probably in everyday life, this so-called the aldosterone angiotensin pathway is also an important regulator out here of these ions and water concentrations. But now what we want to do is we want to think of what happens when, put your phone away, I'd appreciate it. Now what happens when the fluid spills over here into this next series of tubes, the collecting duct. So let me remind you of how we're oriented here. May as well do it on the upper panel. And lay out the position of the collecting ducts in the kidney. Particularly lay out the position of the collecting ducts with respect to the cortical medullary gradient, so that as we think about these collecting ducts, we can begin to envision how the epithelial cells of the collecting duct are facing an ever-increasing concentration of molecules in the interstitial fluid. So there's the kidney. Down here is the renal calyx, simplified a lot, draining into the ureter. The idea here of the cortical medullary gradient, where we've emphasized that the concentration of ions and small molecules are around 300 milliosmoles in the cortex, but can range as high as 1,200 milliosmoles. In the medulla. It turns out, it turns out to get to these high concentrations, the concentrations down here will be about 300 millimolar chloride, 300 millimolar sodium. But you notice that's only 600. The remaining 600 is generated by urea. It's about 600 milliosmoles. And since this molecule doesn't dissociate, this is 600 millimolar urea. So that's where the 1200 comes from. But now let's review the idea of up here. We have the Bowman's capsule, the proximal convoluted tubule, the descending limb of the loop of the nephron, around the hairpin turn, back up to where we began today here in the distal convoluted tubule. And how these distal convoluted tubules then, I'll put this in a different color. Pick one. Empty into this structure known as the collecting duct. Now, formally, the collecting duct is not part of the nephron. You leave the nephron at the interface between the collecting duct here and the distal convoluted tubule. But now the fluid flows into the collecting duct, and as usual, we have a tube made of these epithelial cells. So this is meant to be the epithelium of the collecting duct. So now we have fluid inside the collecting duct, which typically, if it spills over here, is something less than 50 millimolar sodium and 50 millimolar chloride. It's spilling over into the collecting duct and flowing down through this tube. But remember, just on the other side of the epithelial cells forming the tube is this corticomedullary gradient. So the fluid inside the tube is facing an ever greater concentration of ions and small molecules in the interstitial space. Now let's imagine a set of circumstances where you haven't had anything to drink for a day or two. So you're really, really thirsty. And in response to that thirst, the homostatic mechanisms here are going to want to do what? They're going to want to retain water. So how are we going to retain water? Well, we're going to retain water because there will be cells in the hypothalamus. Cells in the hypothalamus will recognize that the osmolality of blood is beginning to go up. It's getting salty in here. So they recognize an increase in blood osmolality. These cells then send a signal to the neurons that release vasopressin. Now remember that vasopressin is released from the posterior pituitary. The vasopressin now is being released from the posterior pituitary and getting into the blood. Remember, the posterior pituitary is just an extension of the hypothalamus, and that there are neurons in here that release vasopressin. Vasopressin is a peptide hormone. It's a peptide hormone that binds to G protein coupled receptors in collecting duct epithelium. So if vasopressin is represented by that orange star, these epithelial cells down here will have G protein coupled receptors for the orange star. The binding of the G protein coupled receptor to vasopressin, let me increase the size of these cells, where this is the basolateral surface, where we find the G protein coupled receptor. The binding of the vasopressin to the G protein coupled receptor starts a cascade of events. It actually turns out that it works through G alpha S and increases the insertion in this membrane down here of aquaporins. Particularly, it's AQP2. Now, what will actually happen here is there's a large reservoir of vesicles that contain the aquaporin 2. And the binding of the vasopressin to the vasopressin receptor tells these vesicles to fuse to the plasma membrane and incorporate the aquaporin 2s. So now look what we're doing. We're really thirsty. We're trying not to pee away as much water as possible. And so what we do then is our thirst activates these cells in the hypothalamus to release vasopressin. The vasopressin now binds to these vasopressin receptors down here in the collecting duct and puts aquaporins into the membrane. So now we have a water pathway across these epithelial cells. And the water pathway now is such that as it gets saltier and saltier and saltier in the extracellular space, the tendency is for water to leave. And we'll see here in a moment, maybe next time, be taken up by the blood vascular system, particularly in the vasa recta, and return to the blood vascular compartment. So in this way, we allow for the contents of the collecting duct to come to equilibrium with the interstitial space. And we do this by letting water leave. Now, as an additional caveat here, the other thing that vasopressin does, in addition to putting in water channels, in some of these basolateral membranes, it will put another protein in here, which is a urea transporter. And it's a one-way trip. So now any urea that happens to be spilling over here into the collecting duct is now pumped out into the interstitial space to help increase the concentration of small molecules out here in the interstitial space to provide an ever stronger osmotic draw, pulling water out of the collecting duct back into the interstitial space and back to the blood vascular compartment. The last minute. Let me draw one other character in here. I'm going to put it in purple. There's going to be another structure in here which runs in parallel with the juxtamedullary nephron. The structure in purple is meant to be the vasa recta. The vasa recta is a branch of the efferent arteriole. So these efferent arterioles branch in three ways. Remember, these are efferent arterioles coming, and it's gone. The efferent arteriole coming out of the glomerulus branches to give rise to the peritubular capillary around the proximal convoluted tubule, peritubular capillary around the distal convoluted tubule, and then this blood vessel that follows in parallel with the collecting duct, and the blood is moving in this direction. Again, now we see that blood osmolality reaches equilibrium with the interstitial space. So as the blood is flowing through this blood vessel, it too comes to equilibrium with everything that's on the outside. So down here, the blood vascular compartment is going to be isosmotic, about 1200 milliosmoles, with the extracellular space. But as it now rounds the bend and moves back out here and will empty into the venous return, out here it's back to 300 milliosmol. The function of this vasa recta is to maintain the gradient. If you block the blood flow into the vasa recta and you prevent blood flow through this system, the cortical-medullary gradient breaks down within a matter of hours. So you have to have the blood flow through this blood vessel to maintain the cortical-medullary gradient. Now, to be sure, it's the juxtamedullary nephron that's setting up the gradient, but it's the vasa recta that maintains it. And with that, I'll let you go.